they survived. And finally, of course, I would say that prevention is better than cure. If you are practicing, advise every patient who has not received vaccine against pneumococcus, against Haemophilus or pneumococcus, and if there is meningococcus, please advise about that. And if you live in JE and endemic or JE epidemics are occurring, then JE vaccine is now effective and can lower the incidence of JE by almost 72%. So practice immunization and prevention. All that I want to say at the end of it, if you follow a approach, treating CNS infections is not difficult. Making a diagnosis is important for a specific therapy. Supportive therapies' role are very debatable. In children, something do work, but they do not work in adults, and vice versa. And so glycerol and dexamethasone, there are two agents which could be used, but dexamethasone mainly for the adults. And fluids should be given adequately, and so the blood pressure should be maintained by giving fluids and inotropes, and that can help improve the outcomes. Thank you.
Hello.
If I understand you correctly, then for adults also mannitol should be discontinued and hypertonic saline should be used.
Yes, but data on that is not available.
Okay.
This is the data from children, and what we found with hypertonic saline is not only that,
3% saline or 7%?
3% saline. And maintaining a sodium which is about 145 to 150.
Any guideline to use inotropes in adults, and what blood pressure should be targeted?
So, as I said, the cerebral autoregulation is affected in bacterial meningitis, and I didn't bring that slide to show, but there is a data from adult study from Denmark where they showed that autoregulation is lost in patients with bacterial meningitis, adult patients, and it is regained once they recover from the meningitis. During that time, their cerebral blood flow is dependent on how is the blood pressure. So they become pressure responsive or pressure dependent. In that pressure dependent, those patients, maintaining a good blood pressure can maintain a good cerebral perfusion. The study that we did was, of course, on children. Yeah.
But what target an adult would? You said 95th percentile.
So if you want to extrapolate data from head injury patients, where they have used in adults is the perfusion pressure target of 65 millimeters of mercury. Raise the blood pressure with noradrenaline to a level that the difference between the mean arterial blood pressure and ICP is 65 or more, the survival is better in patients with traumatic brain injury. And in fact, most of our learning for treating raised ICP had been from traumatic brain injury. In children, when we did, our target was initially 65, but that is not achievable. And we looked at our initial preliminary data, and we thought even at 55 to 60, the patients are coming out intact. And therefore, in children, we may have lower targets. We also know ICP is higher in adults as compared to children, and it goes up with the age. So for adult target is 65, for children it may be lower.
Did you raise the head end of the child, all the children, or they were put flat because you want more?
The standard care for all patients with raised ICP was given, which included keeping head end at about 15 to 20 degree, sedation, maintaining normoxia, normocarbia. Those goes without saying.
Thank you.
Sir, excuse me, sir. I had one query that you said about glycerol and 3% NS. These two things are good for the children. So in first 48 hours, should we continue with the glycerol and 3% both together, or glycerol and then later on switch over to the 3% NS for raised ICP?
No. I think the 3% glycerol is not for the patients in ICU. Okay. This is across the board. If a patient is brought with CNS infection,
okay,
and in those patients, we do use glycerol. But if a patient is transferred to ICU is comatose with the GCS below 8, may not be given oral glycerol.
Okay.
Then you have to give something IV.
Okay.
And there we use 3% saline.
Okay.
But not both together.
Okay. And sir, one more query that you said the treating the patients by CPP way compared to the ICP, it will reduce a lot of mortality and other these
Yes.
side effects. So how can we do a practically CPP?
So that's what I was saying, that practically all you need to do is to keep the blood pressures of these patients around 90th centile. Not that all of the patients are going to be benefited by it, but a majority is going to be benefited. So translating our research into the simple guideline is patients with CNS infections should have a blood pressure maintained at a higher level with the hope that it will improve cerebral perfusion pressure. There will be some patients who will not improve and where the responsiveness to this pressure may be worse, because if the blood pressure goes beyond a certain level, the increased cerebral blood flow means even further worsening of ICP. Yeah. And that is generally seen in our data, it was seen within first 24 hours itself. So if a patient is not showing an improvement within first 24 hours or showing an improvement within first 24 hours, could be taken as very good guide whether he can be benefited by cerebral perfusion pressure.
But CPP is also, the ICP, reducing ICP is also indirectly increasing the
yes,
CPP.
but you know what probably is important to appreciate is this. In this graph, you can see that with CPP target, the your cerebral perfusion pressure is much better as compared to when we have reduced the ICP. This is the lower curve. And interestingly, even in those patients where cerebral perfusion pressure was target, the ICP came down, which is part of the autoregulation being re-established in these patients. Because once you have the cerebral perfusion pressure maintained, their ICP came down. And this was the finding from our previous data as well. This was our pilot data. And here are the group of patients in the lower curve, which were a few, but in first 24 hours, you can see their ICP went just haywire after we tried to increase the cerebral perfusion and increase the blood pressure. But those who responded, they had beautiful, almost predictable curves. With improvement in the blood pressure, there was also improvement in cerebral perfusion. And you can see that in first 24 hours, we were able to achieve an improvement in perfusion pressure by almost 15 millimeters, which did not happen in ICP targeted group.
Just very quickly, I have just, they're getting late. Just I will sort, just let me speak, it may solve a lot of queries. I have just reviewed for this ISCCM the whole literature, osmotherapy in general. In fact, for bacterial meningitis in adults, we don't have much of the data what sir is saying, but definitely in bacterial meningitis, there is a raised intracranial pressure. It's a kind of mixed edema, it's a vasogenic as well as cytotoxic edema. Glycerol in adult, because of this reflection coefficient, is not advisable as far as us is concerned, because it doesn't work in any way. Whenever we go to concept it reducing intracranial pressure, we go to with the reflection coefficient of the fluid, which 3% NaCl has got 1, mannitol has got 0.9, and glycerol has got 0.5. Precisely that is the reason glycerol is not useful. Why it works in children, I'm not aware. But in adults, neither in traumatic brain injury, neither in any form of edema is useful. Same thing happens with mannitol. It has tendency to cause rebound raised intracranial pressure. That's why we don't use it. 3% NaCl in bolus dose. When you are using, you have to monitor the osmolality as well as sodium. You have to make it sure it should not go at any time above 290. Maximum 295 you can go in osmolality. If it goes above 300, it can paradoxically cause cellular injury. About the maintaining of cerebral perfusion pressure, whatever data we have is help from traumatic brain injury. And there is a trial which says when you monitor intracranial pressure, it doesn't make much of the difference. So now what we have done, more and more we are using optic nerve dimension measurement, and according to that we use osmotherapy. Since we know that a critical pressure above 25 is going, then patient will be having severe raised intracranial pressure. We monitor that and we maintain a maximum mean arterial pressure of around 90 to 100, and when you maintain that blood pressure, it's ensured that in adult at least you will be able to achieve a cerebral perfusion pressure of 65 plus, and that's what our target is. So what we do, there are certain things which monitoring doesn't help. We go by the non-invasive monitoring of optic nerve dimension diameter. We go by the mean arterial pressure of around 90. That means we need a invasive arterial line when we are measuring this kind of pressure. We use bolus dose of 3% NaCl. I do not use mannitol in my practice at all. If at all I have to use, that also we use if somebody insists, like neurophysician are fond of using, they don't accept the concept of still 3% NaCl. So if at all some neurophysician involved insist, that also dose we use single dose mannitol and we see the effect and monitor it. So basically when you are using osmotherapy, is giving the drug, seeing its effect, what your target is, how long is sustained. There is no point in giving 6 hour, 12 hour, or whatever way you give mannitol. 3% NaCl definitely looks better because even you can give in hemodynamically unstable patient. It doesn't cause much of the diuresis, so the after effect of mannitol is also less. So it was a summary for adult.
What optimum diameter you target?
In Indian, 4.5. Lots of data, full. No, actually, what happens, no, again, why I'm saying the 7.5% is not available in India. That's why we have replaced. That's why you have to monitor. With 7.5 also, you give bolus dose and monitor the osmolality.
Using 7.5% is not the option here. Because you don't want to raise osmolarity very high. Very high sodium levels have been also shown to be associated with poor outcome. And therefore, we are talking of mild increase in osmolarity in the intracranial compartment and circulating compartment. And although you may not be able to do the osmolarity, sodium levels are good guide. And that's why I said 145 to 150, maybe maximum 155. You should never go beyond that. Let the sodium go above it. In acute in a situation where there is a patient decorticating, a dose of mannitol could be used along with hyperventilation, which I did not mention, but that's only for that acute situation because mannitol works very fast. In 20 minutes, mannitol would reduce cerebral edema, whatever you want to. By the time your dose is gone, it would have its effect. But the diuresis that is caused destabilizes hemodynamics. We have to take care of that. So if you have a diuresis associated with mannitol use, take care that you immediately have replenished the circulating volume. And that's why, as Dr. Mishra also said, hypertonic saline serves both the purpose. It expands the intravascular volume. It also creates a osmolarity gradient, and therefore both of these help the patient.
Sir, shall I say something about adults, sir? Sir, yes, sir. As far as management of perfusion pressure is, what we need is that any perfusion pressure above 70 is good for adults. So cerebral perfusion pressure has to be maintained above 70. That is what is required for adults. And for that you need a mean arterial pressure of 90 to 120. That is one thing which is recommended. And secondly, use of mannitol and hypertonic saline. And till date, as far as literatures are concerned, although there are many negative studies, but nobody says don't use mannitol or don't use other hypertonic saline or so. The concept is that if you are using mannitol, you should not cross the osmolality of 320 milliosmoles per liter. And if you are using hypertonic saline, you should not cross a serum concentration of 154 milliequivalents per liter. That is what has been recommended. And third thing, as far as rebound cerebral edema is concerned, it can happen with both hypertonic saline and mannitol, and that happens because of so-called as idiogenic osmoles. What happens because of traumatic brain injuries? The capillaries, they become leaky, and that is why the higher osmolar concentrations solutes, they go out of the capillaries, they get deposited in the brain, and the thing is that if we keep the osmolarity of the blood for prolonged time in a higher state, then only this thing happens. But if you give it at a fast, like mannitol, we use it as a very fast infusion, so it stays for a very short time and it comes out. So that's why if it is used intermittently, like in 4 hours or 6 hours or 8 hours duration, nothing is going to happen, whether it is mannitol or whether it is hypertonic saline.
I think about the part of rebound is much worse with mannitol. And in fact, I have not shown our data on saline versus mannitol, but the fall in pressure, intracranial pressure with mannitol is like intermittent. With saline, after the bolus, you maintain a infusion, and with that, once there is a fall, it stays smoothly. And that is the reason why the outcomes were much better. Yes, our bolus followed by an infusion to maintain cerebral sodium levels. That study actually was presented last year at so serum sodium have to be monitored.
Listen, the dose of sodium, the target of sodium is 154. So, what we do, we monitor the current sodium level, we look for the target sodium level, and then we look for the total body water. The same formula, so target sodium minus, listen, sir. Target sodium minus measured sodium divided by the target sodium into total body water is the sodium required to get that sodium level. The first we look for the sodium requirement, and suppose sodium requirement has come out to us around 100 milliequivalent, whatever, and like in 100 ml, 1 liter of the 3% NaCl will give you 550 more equivalent of the, suppose that requirement comes around 100. So in 1 liter, it is 554. The 100 ml will be 50. So you give 200. Accordingly, we decide the bolus dose. After that, we measure the sodium level after 2 hours. Once we have measured it, it has achieved, then you start the infusion. When we are giving infusion, every 4 or 6 hours, you have to keep on monitoring sodium level and see for it. That's what it is. Sorry? If overshoot, you have to reduce the dose. If it's under, you have to increase. But it's basically monitoring and adjustment with formula, because that formula is not 100% for even deficit or excess. But that's what we have baseline to start with, monitoring and adjusting the dose. That's what the second step is. Yes. No, sir. He wants to know, suppose your serum level is 135, you want 155, your depth, how much you want to increase? 20 into total body water. Suppose patient is 60 kg, so your body water will be how much? Sorry? 60% of that. हाँ, तो 60 kg का 60% कितना हुआ? 36 into 20? 720 divided by total body water. Again divided by same formula. And that will be your sodium. It's a formula, but I also don't remember. When it happens, I write, calculate, and start. I don't put my brain in remembering all this. Lots of things I have to do. But that's what we do like that. This method, if you know, because this formula is available everywhere in our mobile, laptop, everywhere. Just you have to put it data and comes. But, yes. No? I start with 100 ml. Yes. Just bolus. It goes in 10 to 15, 20 minutes. Yes, first. It will not cause cerebral pontine malnourishment what you have. Its CPM happen only when there is a chronic hyponatremia. It does not happen when you are correcting sodium acutely for this for changing osmolality. CPM is a totally different concept. It happens because hyponatremia. You can't give 3% NaCl in a stable patient where sodium is even 100, even 110, because their cell has adapted for that and need to correct the sodium over a period of 48, 72 hours. But here, when you want to change osmolality acutely to reduce the intercellular volume, that's the only way you can shift the fluid. Here, it will not cause CPM, okay? You go for lunch and can we come at 2:15? Because I want to finish by 3:15. Half an hour, okay? ठीक है. हाँ, 2:15.
Good afternoon, colleagues. I hope you've had a good lunch and we can set the ball rolling in this post-lunch session. I'm going to keep this lecture very light in the sense it's more of an interactive talk. So most of you probably are practicing urinary tract infection management. So this is more of a question-answer kind of a session. I'm just going to give you certain pointers. We'll revise a few basics and maybe a little bit on the advanced management. So urinary tract infection is one of the most common bacterial infections in the general population, as all of you know. In fact, it's as high as 18 per thousand. And usually we classify urinary tract infection into community-acquired infection. That is, a patient who lives in the community has no contact with healthcare surroundings. A patient with healthcare-associated infection, where a patient has some contact with healthcare surroundings. For example, a patient who goes to the nursing home for dialysis, a patient who goes to the center for chemotherapies, stays there for a period of 4 hours and comes back, and a patient who develops nosocomial infection, where the patient is in the hospital for almost 5 days before he develops an infection. So that is how we classify any infection for that matter as of today. In fact, in the hospital, urinary tract infection is one of the commonest nosocomial infections. Most of these infections are bacterial, but occasionally you would also get fungal infections. So let's start rolling with a few cases. So this is a 62-year-old man. He presents with his first episode of urinary frequency, urgency, and dysuria. His urine analysis, which is commonly asked for at this point of time, shows pyuria and bacilli. So my question to you would be, what would you suspect? Is this a complicated infection or is this an uncomplicated infection? I would need fast answers because they have timed me at 20 minutes and I would run out of time for my slides. So raise of hands, how many of you feel it's complicated? And how many feel it's uncomplicated? So most of you feel this is an uncomplicated infection. So let's see what the literature says. What is a UTI? Basically, it's microorganisms in the urinary tract that cannot be accounted for by contamination. And in fact, young women are particularly susceptible, and 40% of the women in their lifetime will develop one UTI. However, in the males, it is less frequent, and the frequency increases only after the age of 50 years, where the ratio between male and female is almost the same. This is the urinary tract system, as you can see, and the reason why people don't develop urinary tract infection is because of the antegrade flow of urine from the kidneys to the bladder through the urethra. And this flushes out all the bacteria. And anything which obstructs this flow of urine will lead to infection. So it could be a stone, it could be a stricture, it could be a tumor, or it could be instrumentation, or it could be a simple catheterization. Anything which pushes the urine antegradely will lead to urinary tract infection. So in fact, infections which involve the bladder, the urethra, and the prostate are classified as lower urinary tract, and infections which involve the kidney, the pelvis are classified as upper urinary tract infections. So what is an uncomplicated infection? So any infection in which there is no structural or functional abnormality in the urinary tract which interferes with the flow of urine is classified as uncomplicated, and the commonest example is healthy females of childbearing age. While as far as a complicated infection is concerned, any obstruction to the flow of urine, it could be a structural or a functional abnormality, or a compromised host, like a diabetic patient, patient on chemotherapy post-transplant, a pregnant patient, or a patient who is having a bacteria with increased virulence and antimicrobial resistance. In short, high-risk patients where treatment has a likelihood of failing are classified as complicated urinary tract infections. So it not only includes functional and anatomical abnormalities, it also includes immunity of the host, as well as the fact it includes the virulence of the bacteria and your prevailing resistance patterns. So any infection which falls in this group is a complicated infection. Why is it important to identify a complicated infection? Simply speaking, because it would require more diagnostic testing, it requires more broad-spectrum antimicrobial therapy, and it requires longer duration of treatment. Also the fact you will need urology reference because interventional procedures to relieve obstruction would be needed. and the complication and mortality rate in complicated infections is much higher as compared to uncomplicated infections. Last but not the least, these are the patients who would come back to you with recurrent or relapsed urinary tract infections. So my question was, is this gentleman having a complicated or an uncomplicated infection? And this gentleman is 62 years of age. Most likely he has a benign enlargement of the prostate, and most likely that is causing obstructive uropathy. So this is a complicated infection. And in fact, in males, all infections should be considered complicated unless and until proven otherwise. In females, you can have uncomplicated, but in males, most of the infections are complicated. Let's go to another case. This is a 21-year-old woman presenting with her third episode of urinary frequency, dysuria, pyuria in the last 4 months. 3 episodes in 4 months. So what type of infection does this lady have? Complicated or uncomplicated? Complicated, how many? Quite a few of you. Uncomplicated? Okay, few of you. This is a 50-50. So let's see what happens. So what are recurrent UTIs? Recurrent UTIs are greater than 2 symptomatic infections in 6 months or greater than 3 in 12 months. I'm sorry, this pointer is not working, but this is the site you have to see. In 12 months indicate recurrent UTIs. In men, more than 1 episode at any point of time indicates recurrent UTIs. In recurrent UTIs, you have to have documented cure for at least 2 weeks. So there should be an interval period of 2 weeks before you get a fresh infection. So anything after 2 weeks is a second infection. Now recurrent UTIs could be because of reinfection or relapse. So what is a reinfection?